Hello, I'm Dr. Roger Henderson. I'm a GP and I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. In this episode, I'm going to be discussing a condition that most of us as GPs encounter early and often. And yet, it is one that continues to challenge diagnostic reasoning when it strays from the expected course. And that's acute laryngitis. Now, this is frequently dismissed as a minor illness, but careful listening, both to the patient and to the patient's voice, can reveal important clinical insights. So at its most basic level, acute laryngitis simply refers to inflammation of the larynx resulting in voice disturbance. Now, the distinction between acute and chronic disease is primarily temporal, with acute symptoms generally resolving within 2 weeks. If voice changes persist beyond that window, then as GPs we should consider either an unresolved trigger or the transition to chronic laryngeal pathology. Now, as we know, patients typically present with an abrupt onset of hoarseness, vocal roughness, or loss of vocal clarity. And many describe to me a sensation of effortful speech or early fatigue, particularly those who rely heavily on their voice for work or performance. And as the condition progresses, some patients experience a near complete loss of voice, which can be alarming, but remains consistent with severe laryngeal edema rather than any neurological dysfunction. Now, accompanying symptoms often can provide important clues. A dry cough, throat irritation, or a sense of fullness in the throat is common. A low-grade fever or generalized malaise suggests an infectious etiology, whilst isolated voice symptoms without any systemic illness should prompt consideration of non-infectious causes. But what should immediately raise concerns, however, are symptoms such as significant shortness of breath, stridor, drooling, or painful swallowing, and these findings are inconsistent with simple acute laryngitis and so require urgent reassessment, as they may indicate things like epiglottitis, deep neck infection, or obstructive pathology. Now, from an etiological perspective, viral infections account for the majority of acute cases. So these patients often describe a classic sequence of nasal congestion, a sore throat, a cough, and then their voice changes when the larynx becomes involved as part of a broader upper respiratory inflammatory process. While bacterial laryngitis is uncommon, secondary infection may occur after an initial viral illness, particularly when symptoms worsen rather than improve after several days. Now, importantly, as clinicians, we should always resist the reflexive use of antibiotics. Evidence does not support routine antibiotic therapy in otherwise healthy individuals, and inappropriate prescribing contributes to resistance without improving outcomes. That being said, immunocompromised patients, smokers, or those with severe or progressive symptoms do warrant closer scrutiny and a lower threshold for targeted treatment. Non-infectious acute laryngitis often presents more subtly but is just as prevalent. And acute vocal overuse is a frequent culprit here and is often underappreciated in the history. A single event, such as shouting at a football match or a concert, prolonged speaking without rest, or performing outside one's trained vocal range can all be sufficient to trigger inflammation or even submucosal hemorrhage of the vocal cords. And these patients typically report sudden voice loss following heavy use rather than a gradual onset. Gastroesophageal reflux plays a particularly complex role here. This can cause acute or episodic laryngeal inflammation, but without classic heartburn. And repeated exposure of the laryngeal mucosa to gastric contents leads to edema, altered sensation, and compensatory voice behaviours. Patients may complain of frequent throat clearing, a chronic cough, or even a persistent sensation of globus. Now, because symptoms are often worse in the morning, this history can help to distinguish reflux-related laryngitis from infectious causes. I also think that asthma and inhaled medications also deserve attention here. Chronic coughing can mechanically traumatize the vocal folds, while inhaled corticosteroids may cause chemical irritation or even predispose to fungal colonization if proper technique and rinsing aren't used. Environmental exposures, including tobacco smoke, industrial pollutants, or even strong fragrances, may also act as irritants and trigger acute inflammation in susceptible individuals. Now, as we all know, functional voice disorders complicate this picture even further, and these patients may present with dramatic changes to their voice in the absence of any visible pathology. Now, while this diagnosis should never be made casually, psychosocial stresses such as bereavement or occupational strain are well recognized precipitants and so must be approached with sensitivity. Understanding the pathophysiology of acute laryngitis helps to explain both the symptoms and the management strategy. Inflammatory mediators lead to vascular congestion and edema of the vocal folds. As this swelling increases, the vibratory properties of the mucosa change, requiring higher subglottic pressure for phonation to occur. Patients then instinctively compensate by pushing their voice harder, which paradoxically worsens the trauma and prolongs recovery. In severe cases, edema disrupts normal vocal fold contact entirely, resulting in aphonia. And while alarming to patients, this is typically reversible, although maladaptive phonatory behaviours learned during this acute phase may persist, and explains why some patients experience prolonged hoarseness even after the inflammation has subsided. Now, the clinical evaluation of a patient with acute laryngitis begins with a careful, structured history and onset, duration, progression, and associated symptoms all matter here. Any prior episodes, occupational voice demands, medication use, smoking history, and immune status should be explicitly addressed. Now, in most cases, the diagnosis is purely a clinical one, but if possible, visualization of the larynx provides valuable confirmation and reassurance. Flexible laryngoscopy typically reveals erythematous, oedematous vocal folds with thick secretions. Movement, though, is usually preserved, helping distinguish laryngitis from neurological disorders, and in the cases of vocal trauma, hemorrhages or early nodular changes may be visible. And these findings reinforce the importance of early voice rest to prevent any chronic injury. The management focuses on creating an environment that allows the larynx to heal, and resting the voice still remains the most effective intervention here, although patients often do struggle to adhere to this. Education is therefore key, and patients should understand that whispering actually increases strain, and so short, quiet speech is preferable to whispering if communication is necessary. Hydration and humidification both support mucosal recovery, whilst the avoidance of irritants also accelerates resolution. Pharmacological therapy has a limited but targeted role, So acid suppression may benefit reflux-associated laryngitis, particularly when combined with lifestyle modification. Antifungal therapy is always reserved for confirmed cases of fungal infection, and I think it's important to remind us here that the routine use of steroids or antihistamines lacks any strong evidence and may provide false reassurance whilst actually delaying recovery. Fortunately for all of us, though, the prognosis for acute laryngitis is overwhelmingly favourable, and most patients regain their normal voice function within days to weeks at most. Those who don't often benefit from early referral to speech therapy, where targeted treatment can prevent any progression to chronic dysphonia. So that's a very quick overview of acute laryngitis, and I do hope you found this podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. We really do love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and also to download free shortcuts to help improve the lives of all our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.